Hey guys, it's Sam. So, as you can probably guess, we're going to talk about chest tubes. Um, I cannot reach all of you in huddle, so I decided to make a video of a couple things just so that we could talk about chest tubes and make sure that everyone kind of understands what they need to when taking care of a patient with a chest tube. So, I'm just going to go over first the different parts of the atrium. So, you've got your collection chamber here, obviously. That's where all your blood or fluid would collect in, and we usually take a Sharpie and mark that with the hour. A couple other things. This is the water seal chamber. So sorry you can't see that. This is where we're going to watch for any bubbling, and that's going to let us know if there's a problem with our chest tube. This is where we would look at our titling. So just to make sure that there's adequate pressure inside of where the chest tube is. So the bubble will move up and down with inspiration and expiration. Up here is the suction pressure. Sorry, you can't see that very well. The suction pressure. So it's normally set at -20. I'm going to say if surgery doesn't set it on something different, they probably want it on -20. So keep that in mind. And then also you've got your bellow here, which is this orange thing. I'm going to actually turn the suction on and show you what it should look like when suction is attached. So, as you can see, that bellow is all the way out to that titch mark, which is where we want it to be. That lets us know that there is enough suction. Now, so if there wasn't enough suction to that atrium, you can see that bellow, well, it's still kind of pretty good, but it's not quite out to that titch mark. So the best thing you can do at this point is to increase your suction on the bowl. And once you turn it back up, you really want it to be at least 80. So once you have that up there, you can see that bellows back out where it needs to be. A couple other things, this base down here, as you guys know, that's for stability. We usually end up taping that to the floor so that it doesn't accidentally get knocked over. And then one thing I wanted to point out, this back here, up here kind of on the top, that is the positive pressure release valve. So if we have too much pressure in the atrium, it will automatically release through that valve. It's really, really important to note, do not block that valve. So, a couple things that happen in your room when you have a chest tube. You've got your 4x4 gauze, your sterile gauze. We don't actually have to have petroleum gauze anymore. Sterile gauze works just the same, just something that will cover that insertion site. And tape. You can use a Tegaderm or whatever it is that you feel you want to use if the chest tube comes out. Usually what we'll do is tape 3 sides of that, and the 4th side of the gauze is open to allow air to get out. So, a couple things. When you, let's say you've got a patient who's hooked up to their atrium and they filled their atrium, so you need to change it out. So, first thing is, on the back here, there's going to be like a little vial of saline. I only have a pinky right now because this has already been used, but we'll just say, for showing purposes. You're going to insert it through the suction port up here, that little blue port. That's where you're going to put that fluid. It's actually 45 mLs of fluid. So once we get that in there, what you're going to have to do is disconnect your patient from the old atrium and connect them to the new atrium. So how do you do that? So first off, have your new atrium ready, have the water seal set up and all that stuff. Secondly, we need to clamp the patient off so that they don't get, any possible air or anything. So it comes with a clamp on it, so you can use that. If you're kind of extra careful like me, I use hemostats as well. So you can use hemostats and clamp them on 2 separate sides or just one, however you want to do it. So you can clamp that down like that. So once you have that clamped, you have this connection piece right here. So you're going to press down. Let's see if I can show you. Press down on here and pop it off. It's very, very easy. So you'll pop it off, scoot the old atrium out of the way, and put them back in. Now, this is just like you would treat, a central line or anything. You don't want to be touching the tips of these. You want it to be as sterile exchange there. But it's really nice because it keeps it all one piece and there's no, you know, no complexity to that. So once you get them hooked up to the new atrium, you're obviously going to unclamp. After you unclamp them, then at this point is where you would determine, okay, are they water seal or are they suction? So a person that needs suction, you're going to go ahead and attach the suction after you connect the patient. Don't connect the suction and then the patient. So got our suction back here. You're going to put that on the suction head, that blue port on top, and you're going to turn your suction on. Now, let me keep in mind that there's going to be bubbles because this isn't an actual chest tube in a patient. So then you're going to turn your suction on. And like I said earlier, you want to make sure it's at least 80 off the wall to make sure that this bellow is out where it needs to be, which it is. So, a couple things I want to talk to you about. You know, with the suction, that's great. If you don't need suction, you just need a water seal. It's as simple as taking this off. I know people get really confused about water seal. It's sealed by the water that's in this. So you just take the suction off and you're good to go. So, either time, if you're on water seal or suction, we're going to talk about a little bit about troubleshooting. So, this is very aggressively bubbling because it's not actually in a patient, but let's talk about if, you know, your chest tube atrium is bubbling this much. So this is a huge issue. Clearly there's something going on. So at this point you would want to troubleshoot, you know, is my chest tube still in? You know, are the connections still tight? Because that's the first thing that's probably going to come loose. And also, you know, is there any puncture holes or anything in my tubing? So the way that you're going to kind of troubleshoot that is you're going to start at your insertion site. You're first going to make sure the chest tube is in. You know, or like one, you know, it hasn't come out so far that one of these little holes is actually sticking out of the patient. So you want to make sure that it's in. Then you're going to look at your connection. So this is your first connection. Usually we will have this taped just to make it a little bit stronger, but you're going to check at that connection. And as you kind of check, you're going to go down, you know, in clamping. You know, if it's still bubbling when you clamp this, you know that, you know, it's probably not just the chest tube. So you're going to keep going down until you find where it stops bubbling. And that's kind of where it's going to tell you, okay, you know, that's where the issue is. So, something to keep in mind with that. Another thing to watch is your titling, which I can't really make this title right now, but this little ball down here would actually kind of go up, down, up, down, up, down. That's titling. So with inspiration and expiration, it's going to go up and down. So that's a good thing. That means that you have good suction and, you know, there's no issues with your tube. If it stops titling, something to keep in mind is that your tube could be clotted off, could have come out of the patient. So again, just troubleshooting that. If you do have a clot in your tubing, we do not strip our tubes on our side. If, you know, say cardiology or someone like that is wanting you to strip a chest tube, you need to go ask the APN and ask them to go ahead and strip that, because we aren't really trained to do that. Trying to think what else. One other thing I wanted to cover is don't ever clamp a chest tube unless it's ordered. So there's no intermittent clamping of chest tubes. We normally only clamp when we're about ready to take the chest tube out, so kind of giving them a trial beforehand to make sure that they're going to do okay without the chest tube. But don't clamp it when you're getting the patient up. Don't clamp it when you're transporting, none of that. So just keep that in mind because it can actually cause a tension pneumo. And we obviously don't want that to happen. So just keeping that in mind. Some things about transporting your patient with an atrium. Again, like I said, don't clamp it. Make sure that this stays below the patient's chest because you don't want any fluid going back into the patient, obviously. They do have these hooks on the top here that you can, you know, hang it to a pole or the bed or anything like that if you would need to. And other than that, changing the dressing. So normally ped surgery will have you take your 4x4 gauze and do one above and one below the insertion site, kind of overlapping, just to make sure you have that good seal, and then put tape over it. If your atrium gets knocked over, They do say that all the fluid inside of here is separated, but personally I just always get a new atrium just because I want to make sure that it didn't mess with my levels of anything in there. So I think that's it. If you guys have any questions at all, please come find me, or come find Megan or anybody that can help you set that up.